Hey guys, this is case study number 9. We are dealing with terminal illness by Mandy and Keena. Our introduction population is terminal illness. A person may be regarded as having a terminal illness, which is an illness or disease process that is not responsive to curative medical treatment and which will worsen or eventually cause death. When broad agreement has been reached among health professionals that is no longer the possibility of cure and that life expectancy is limited. While terminal illness is our overall arching population, we're going to focus on the end-of-life care, specifically hospice palliative care, which is a whole person health care that aims to relieve suffering and improve the quality of living and dying. Hospice palliative care is appropriate for any patient and or family living with or at risk of developing a life-threatening illness due to any diagnosis, with any prognosis regardless of age, and at any time they have unmet expectations and or needs and are prepared to accept care. Our subgroups are by generation, and we're going to focus on the access for each population. So for children, they have a hard with a lack of communication and understanding, which means children and adolescents have a hard time understanding their own prognosis due to the lack of communication and understanding, which end up leaving them feeling isolated, mistrustful, and anxious. They also are limited to options in palliative care and hospice care services due to based on the overall prognostic factors and requirements for hospice care. You're only allowed to have it through private insurance companies rather than having it through the state insurance company of Medicare, so that limits their options. Adults to strive to maintain self-care through spirituality. It's difficult maintaining religion and spirituality treatment for end-of-life decisions, and the difficulty for managing symptoms due to your age. As your prognosis increases and your age increases, you're more susceptible for pain, and therefore hospice care is the best option due to managing that pain symptoms. The elderly is our last population. It's determine the difference in available resources of care, such as chemotherapy, radiation, euthanasia, and assisted suicide, which we'll discover what that is later. And then if their hospice utilization is based on personal neglect of refusing to receive resources and reach out for help, or if it is based on not having the utilities to take advantage of these resources. Okay, so the summary of our case. Our client is Janelle. She's a 35-year-old mother of 3 school-age children. She's divorced twice, the father of her twin sons, and then the father of her daughter. She's employed as a teacher's aide for more than 5 years, and 1 month ago, she was diagnosed with metastatic breast cancer. Her medical team wants her to undergo aggressive chemotherapy and radiation. She refuses all medical interventions and is choosing to rely on prayer for healing. However, she is currently receiving hospice care services. Janelle illustrates intersexuality, as she is an African American female that was diagnosed with a terminal illness. She recently was able to receive health insurance benefits. She does have limited financial support, and she feels judged by her hospice team due to the delayed response to seeking treatment. Intersexuality through the combination of race, social economical status, and geographical location. Blacks and Asian patients with terminal illness are more likely than whites to be hospitalized for prolonged periods, therefore not really seeking hospice care services. And their access is limited based on their socioeconomic status and due to geographical location. Also, there are barrier services to hospice care based on African American studies that there's a mistrust based on the history of interrelations with African Americans, like the Tuskegee study. Our ecological systems perspective from the broader society, we have our micro, which is the individual, the religious community, employer, close friends, family support. Meso, interdisciplinary teams in developing programs to assist their population. So for Meso is interdisciplinary teams developing programs to assist the population. Macro is policy, law changes, lobbying, advocacy at a local, state, and federal levels. And then based on the ecological systems perspective, the client at a macro is children's, neighbors, pastors, and her immediate family support. Hospice care, her church community, her job as a teacher's aide, Sunday school teacher, church nursery facilitator, community advisor for her neighborhood. Macro is hospitality and health insurance companies. Cultural strengths, resources, and natural support systems of the client. Our strengths are like religion, resources, support. So for the broader perspective, spirituality, religious beliefs, and resources would be like hospice, the hospital, support groups for our different populations and age groups. Support would be family, friends, and community. For our client, that looks like cultural strengths or spirituality driven by her faith, her support system, which includes her immediate family and fellow church members. The church, the hospital, community members, and hospice team are all natural supports and available resources. For power, privilege, risk, resiliency, and advantages, we have a low power and privilege, as she is a single minority woman with low socioeconomic status. She has limited financial support and income. There is a high risk for individuals with no insurance, as they are less likely to seek treatment due to financial support and medical benefits. Like I said earlier, whites and Latino Americans are generally on the same page as seeking hospice care, while Asian Americans and African Americans are less likely to seek hospice care. Resiliency and advantages. We have strong cultural strengths such as community resources and natural support. High advantages due to available government assistance program and government policies.
Okay, and other similarities and differences are subgroups as far as influence on access to services. As far as children, who are suffering from terminal illness, they are often covered under private insurance from their parents. At this time, private insurance companies are not required to cover hospice and palliative care. For those who are receiving federally funded programs such as TennCare or Medicaid programs, those services are usually covered. And there are also some hospitals that offer treatment free, regardless of ability to pay to children, such as St. Jude Research Hospital. For middle-aged adults, they often have private insurance as well and are responsible for various health pays and other out-of-pocket expenses. Currently, the Affordable Care Act does allow for concurrent care to include palliative and hospice care. For the elderly population, they are often covered by Medicare or Medicaid, and many of their treatment services are provided under that. However, all groups have issues with transportation to and from their medical appointments, and more affluent individuals have access to alternative forms of treatment. Some ethical issues in the broader group to consider: the goals of care for the patient, whether it be curative to try to cure the patient of the illness, to prolong life through pacemakers, life support, or palliative care without treatment, which will offer support groups, education, addressing beliefs regarding death without additional treatment. of the illness. Also, informed consent, just ensuring that clients, that self-determination and autonomy with the client so that they know that they are in charge of their medical treatment and services. Also, information must be clearly understood by the client, whether that be translation being needed and asking questions to ensure the client understands, and avoiding technical language with medical terms and adapting the plan to the patient's fears and culture. Other issues to consider would be the do not resuscitate order, the advanced directives, or the living, which is the living will, decision making when incompetent, artificial hydration or nutrition, which is feeding tubes and things like that when the patient is no longer able to receive food by mouth, and sedation, which is offered when palliative treatment is no longer effective and it's aimed at keeping the patient from suffering prior to death. Also, religious belief could be an ethical issue. As with our own client, she's relying on prayer for her treatment and do not want to go through the chemotherapy. Also, there are some beliefs who do not believe in things like blood transfusions. Physician assistant suicide or death, or the death and dignity, is also an ethical issue. This is a doctor knowingly and intentionally providing a person with knowledge and the means to complete suicide. And we will discuss this a little bit later in our presentation. As far as the NASW Code of Ethics and issues that may arise, the ethics and values. So as social workers, we should be prepared for evaluating ethical dilemmas and consider questions related to religion, spirituality, and the meaning of life with patients. As far as knowledge, we should assist the patient in navigating the medical and social systems. For assessment, our plan interventions with the patient based on assessment and reassess and revise the plan as needed. With the intervention and treatment planning, we should always have that initial assessment and discuss that with the team and the patient as input to guide the plan, development of the plan. Attitude and self-awareness, we should always demonstrate empathy and sensitivity. Empowerment and advocacy, we should identify the client's needs and concerns and communicate those needs and concerns with decision makers and providers of care. Documentation is ongoing and should reflect assessment issues that are addressed, treatment offered, and plan of care. Interdisciplinary teamwork. We are to advocate for the views and needs of the client and their families and assist the patient or client in communicating effectively with the team. Cultural competence, we should respect and integrate knowledge about how patients are influenced by their ethnicity, culture, values, religion, economic status, and beliefs about the healthcare system. Continuing education, continue to grow in knowledge and theories in palliative and end-of-life care. As far as supervision, leadership, and training, we should offer our expertise to individuals, groups, and organizations, as well as offer training and mentoring opportunities for those who may be new to the field. So some micro and meso skills, we should identify the task of terminal illness and interventions that can help the patient and their families fulfill those tasks. We should also identify the psychosocial health needs of the patient and their families and the psychosocial health services to address those concerns. Also, other interventions that we should consider would be cognitive behavior therapy, empathetic listening and support, life review, education and communication, dignity for meaning-centered therapy, which is finding the meaning and purpose of life, and group therapy. So we ask that you watch this brief demonstration about palliative care, and it offers 10 things that we should say and do with clients when discussing palliative care. Some macro concerns to consider would be, while there have been some improvements in expanding palliative care, additional reform is needed to address transition patients earlier to hospice, end-of-life coordination, and advanced care planning. We should also advocate for those who struggle to access resources and services in underserved populations such as low socioeconomic statuses, rural communities, and those in advanced stages of illness. Also, more research is needed for studies on the cost effectiveness of hospice and palliative care, especially for federally funded programs such as Medicaid. Advancing human and civil rights. As social workers, we must ensure clients understand their rights, as mentioned earlier, and that they are understand and know that they are in control of their medical treatment. And we should also advocate and be the voice for the client for the medical team. And just to help the clients understand those rights as mentioned earlier, such as self-determination and other rights that they have concerning their medical treatment. Some policies that are currently being advocated for is the Senate Bill 1334, which is Patient Choice and Quality Care Act, which is to amend the Social Security Act to provide for advanced illness care coordination services for Medicaid recipients. Senate Bill 980, the Rural Access to Hospice Act, to provide payment for service for certain rural health clinics and federally qualified health center services. Senate Bill 693, which is to amend the Public Health Services Act to increase the number of palliative care faculty in educational settings to promote the education and research of palliative care in hospice. And the Physician-Assisted Suicide or Death and Dignity Statute, which we mentioned earlier, which allows for qualified terminally ill adults to voluntarily request and receive medications to hasten their death. Physician-assisted suicide is legal in Montana. In California, Colorado, DC, Oregon, Vermont, and Washington, death and dignity statutes are in place. There are currently 24 states that are considering adding laws regarding this. Some advocacy opportunities to consider would be American Cancer Society, St. Jude Children's Research Hospital, Hospice Action Network, National Hospice and Palliative Care Organization, Cancer Action Network, and the National Association of Social Workers. I would ask you to visit these websites. The websites offer a wealth of knowledge about palliative and hospice care and how you can advocate for this population. So in conclusion, if you work with patients who are terminally ill or receiving end-of-life care, we have to listen above all. We must help them understand the medical system, their options, what to expect, and anything we can provide to help them make informed decisions. Just remember, we are that bridge between the patient, their family and support system, and the medical team. For those who do not work with this population, we can still be aware of policies and laws that affect them and advocate for implementation of positive change. So for our class participation, we ask that you watch a TED Talk by Elaine Farn that is titled Design for the End of Life. And upon completing that, we ask you to answer the following questions about what were your thoughts or beliefs about physician-assisted suicide or death prior to watching the video, and discuss how the video either verified your thoughts or caused you to think differently about the issue. We have listed several references regarding information that we've shared today. We ask that you look up any of these references for more information about end-of-life care, hospice, and palliative care. Thank you.